It is my pleasure, great honor to introduce another great friend, Paul Sidhu, professor in radiology at King's College in London, previous deputy editor of British Journal Radiology, nowadays one of the editors of European Journal Ultrasound. He is the president-elect of EFSUM. He is one of the most well-known researcher in many fields, especially pediatric radiology and urogenital radiology. And today, it is a great pleasure to announce that he will talk about multiparametric ultrasound in testis pathology. Please, Paul, proceed.
Thank you very much, Vito. I'm going to talk this afternoon about multiparametric imaging of the testes, but I'm also going to bring in other aspects as well, so you can actually see how all of this fit into examination of the testes. First of all, you probably have, a lot of you have been ultrasounding testes for a long time, and you have this general feeling that all the testicular lesions that you see are going to be cancer. But this is not the case. A lot of malignant lesions, the teaching is that 90% of the lesions that you find in the testes are malignant. But this is based on old data. In the old days, before you had any ultrasound or anything like that, you never found an incidental lesion. You palpated that lesion and it was going to be malignant. But there are also many, many other benign lesions. And the important thing is that you don't want to be doing an orchidectomy, taking out the testes for a benign lesion. Focal testicular lesions are rare, but it's very important to the patient who has that abnormality that you preserve testicular tissue. On ultrasound, there are many, many different appearances. The classical seminoma to the lymphoma, the adenocarcinoma, the teratoma. But what you have to differentiate is this sort of benign appearance and leave that in place from the malignant lesion. These lesions are pretty classical, and you can pick out that these are going to be malignant or non-malignant, but there are many, many what we call indeterminate lesions. And the more and more ultrasound that's done, the more often you're going to find these lesions. And what do you do with these lesions? Do you leave them? Do you subject these patients to surgery? Do you do testes-sparing surgery? Can you make a better diagnosis of what you're looking at by getting all the parameters of ultrasound together? Ultrasound is the best modality for looking at superficial structures like a testicular tumor. You may want to use MRI as a problem-solving tool, but even MRI is probably not as good as multiparametric imaging of the testicular tumor. So I'm going to show you in the next few minutes exactly how we can use the different multiparametric imaging techniques and get to the bottom of that lesion and to the benefit of your patient. Now, just to bring to your attention this paper, which was published some years ago, looking at patients with infertility and finding incidental lesions in the testes. We have been taught that most lesions in the testes are malignant, but in this paper, 80% of incidental lesions on ultrasound are benign. So this shows you just how important it is to get it right. Now, we've heard from Professor Gilger how the EFSUM guidelines have been around for quite a few years now, but in these guidelines it very specifically indicates what you should use contrast-enhanced ultrasound for in looking at focal testicular lesions. Ultrasound is the imaging modality for choice of the scrotum, as I said before, but it's those equivocal misinterpretation that you want to avoid unnecessary orchidectomy. And the key point is the hypovascular, avascular, and vascular lesions, bearing in mind to say that the vascular lesion is likely to be malignant. Contrast-enhanced ultrasound is truly intravascular, so if that lesion in the testes has vascularity into it, there is vessels in there. So you can actually pick out the truly avascular lesion, implying benign disease, quite easily. And just also to draw your attention to this paper, which was published nearly 25 years ago, looking at just color Doppler of the testes to see whether this could be used as a marker for the presence of malignant disease. And there has been no other paper looking at vascularity of focal tumours since then. And this was only 28 patients. And their conclusion was that colour Doppler ultrasound was only a limited role in testicular tumours. This is incorrect now, because we know that we can see vascularity in tumours right down to 4 or 5 millimeters, but does it always indicate that it's malignant? So yes, we can use colour Doppler, and we can improve it with use of contrast. But we've got to make use of all the new techniques, and this is where we use multi-parametric imaging to look at the testes. Use the term multi-parametric imaging for ultrasound, just as you use the term for MRI. There is no difference. Your B-mode ultrasound, your colour Doppler ultrasound, your contrast-enhanced ultrasound, and your tissue elastography, all in combination, make you get nearer to the correct diagnosis. How do you do a study looking at testicular lesions? We've heard earlier on from Helga that when you're looking at small parts, testes, bowel, thyroid, and whatever else you want to use, you use the full dose of contrast. So you have to use the 4.8 mils of SonoView, and this is due to the physics of the resonation and the size of the bubbles. Prior to doing the examination, you should do a full B-mode and colour Doppler examination. The arterial phase is the most important aspect, because you're looking at the vascularity throughout the testes. The testes and the epididymis enhance rapidly, but the arrival time is very variable between individuals, and the older patient, it takes longer. Arteries first, seconds, but later complete parenchymal enhancement. The scrotal wall tends to enhance to a lesser degree than the contents, and there is no accumulation of microbubbles in the parenchyma, and by 3 minutes it's all gone. I tell my residents and people who are new to this is that the best imaging you get in the testes is when there is inflammation in the testes, and you should bear that in mind when you get a little bit disappointed when you're looking at a 2 or 3 millimeter lesion that doesn't enhance so well. Indications for using this: torsion of the somatic cord. Now I must emphasize to you that torsion of the somatic cord is a surgical emergency, and you should not really be doing ultrasound on these patients. However, there can be some problematic patients, or it may be missed and you want to confirm that the torsion has occurred. You may be fooled by the absence of colour Doppler. The technique may be not correct. You can't be confident that there is infarction in that testes. But look, when you add contrast-enhanced ultrasound, it's absolutely clear that there's no vascularity to the testes itself, but there is vascularity to the epididymis, and there are a couple of epididymal abscesses. And if you do the spectacle view, you will see the vascularity in the normal testes and the complete absence of vascularity in the abnormal testes, making your diagnosis very clear with not being equivocal, and you can be confident with this. Another area that you can use it in, and I emphasize that absence of vascularity is much easier to see than increase in vascularity, but we'll get on to that later on, is this entity called segmental infarction. And this happens in an older patient group as opposed to the total enhancement pattern that you see in global infarction. And segmental infarction can be quite difficult to pick up. It can be wedge-shaped, it can be round-shaped. And this is where contrast helps you to delineate what exactly is going on. This is an example of a patient with a segmental infarction in the testes, very ugly looking, almost looking like a malignant lesion. And you can say, well, there's not much colour Doppler flow, perhaps it is a segmental infarction, but you can't be absolutely confident on this. And you will probably want to do enhancement patterns to look at to see whether that is avascular or not. This is a case that we had not so long ago of a very ugly looking lesion in the testes, which with colour Doppler ultrasound you can see there's probably not very much ultrasound signal with Doppler signal in there. But if you add contrast in here, you'll be more confident. And we were confident after adding contrast that we could wait on this lesion. There's no necessity to do an orchidectomy. And this is the same patient a week later with the colour Doppler also showing regression. And this is what the contrast-enhanced ultrasound looked at the same time. And I mentioned to you earlier how an inflamed testes, and this is an inflamed testes, this is a segmental infarction as a consequence of venous occlusion from severe epididymal orchitis, and you can see that that is clearly different, shows you an area of focal infarction, no cut flow in that area, and you can safely watch it. And look at the dynamic examination in this patient. This is after 19 seconds, 20 seconds after injection, and you can see how clear it is that this is a well-demarcated area of infarction. You have the diagnosis, you can confidently wait with that patient and wait for that to resolve. This is another patient with rounded areas of infarction. Again, you can be fooled on this B-mode ultrasound to see exactly what it is. There's not quite a color Doppler flow to the area, and this is the patient 18 days apart. It's almost disappeared, and there's really not much color Doppler flow. And we were confident because this is the contrast-enhanced ultrasound that we perform. Inflammatory response around the area, poor contrast to the rest of the testes, which is quite normal, and very clear demarcation of areas of infarction. And this is it 2 weeks later, or 18 days later, it's almost disappeared. And the dynamics clip will show you how, and within 20-22 seconds of injection of 4.8 mils of contrast, the surrounding inflammatory change, areas of infarction, you can sit and wait for that to resolve. Other forms of inflammation, epididymal orchitis, can affect the epididymis and cause indeterminate abnormalities. And what you're looking for here in these areas in the non-enhancing regions is this is an abscess, an infarction, or whether you need to actually manage this patient differently if there is an abscess, or going on to do an orchidectomy instead of conservative management, because quite often large abscesses cause a lot of pain and can't be fully treated with antibiotics. And this is a patient with an area of venous infarction, and this is a patient with an abscess. And you can see with the contrast-enhanced ultrasound that the border is well demarcated, clean, as opposed to the abscess, which is irregular with septations, very different. It is up to the clinician and the patient's condition of whether or not this is treated conservatively with intravenous antibiotics, or if there is no real use in preserving testes, then to do an orchidectomy for symptomatic release. This you can wait, it will resolve, the patient's testes will be smaller, but he will retain testicular tissue. And this is the dynamic view of this area here, and you can see as it's coming in, you've got hyper-enhancement around the wall, you've got irregularity of the wall, those septations are forming, it's raggedy, irregular, this is an abscess. Another recommendation from the EFSM guidelines is to look at tumors and complex cysts. We've previously seen that the literature indicates that anything less than 1.5 centimeters in diameter in the testes, the color Doppler is not good. But this is not true at the moment. I think this level is down to about 5 millimeters. You'll be able to pick up simple testicular cysts very easily with contrast, but you're looking for that rare cystic testicular tumor as well. Rare and very unusual to see, but if you have vascularity increase in the wall, then you're dealing with a cystic tumor. And let's have a look at some of these tumors in the testes. Now this is a seminoma, and you would say, well, this is very clear on the B mode, and the color with increased vascularity, it's almost certainly a seminoma. And you will be correct just on these two views. But what about adding in the contrast-enhanced ultrasound here? We've found with our experience, and other groups have this experience, and I'll show you some other papers later on what it actually looks like. Well, a seminoma on contrast-enhanced ultrasound will show this very irregular, slow enhancement pattern through the testes, disordered vessels throughout, and very quickly after the initial phase, it'll start to fade away and wash out, and so it becomes darker very much quickly. The period of time enhancement occurs with a testicular tumor is very much less than that you see in the liver. The contrast is more or less all gone after about a minute, and it's very rare that you'll see anything longer than that. unless there's inflammation in the testes. Let's now look at this. This is a Leydig cell tumor. 90% of these are benign tumors. And what does the pattern of vascularity look in that? Well, just looking at these tumors, you'll see that they're much more vascular than that seminoma beforehand, and it seems to hold on to its contrast a little bit longer. A Leydig cell tumor is more vascular in histology, and this may be a test to actually show the difference between those focal lesions of whether one is a malignant lesion and one is a benign lesion. Ourselves and some other groups have looked at this, and Dr. Kantisani is part of a publication in radiology which has looked at this more clearly. But this is our own program, in-house software program designed to look at testicular tumors, and this is what we find. We've targeted the area of the tumor and two other regions of interest in association with how the contrast washes in and out, and the red is the wash in and wash out of the tumor. And in the seminoma, you can see the wash-in comes in and then disappears very quickly to equal that of the regions of interest. Whereas big cell tumor, that wash-in stays higher and remains higher through the period of time, and this is 90 seconds in our studies, to show that yes, there may be a pattern of difference between the seminoma or the primary germ cell tumor and the Leydig cell tumor. Now let's just move on to other focal abnormalities that you see in the testes, and in the older patient it's the lymphoma. Now lymphoma is unique in the testes. The management is the same. You will do an orchidectomy, but you'll be watching the other testes because the incidence of lymphoma recurring in the other testes is high. Lymphoma grows along the structures of the testes. It doesn't destroy the testes. So there's linearity in the color Doppler flow within that lesion, and this is mirrored in the contrast enhanced ultrasound examination and the color Doppler ultrasound examination. So this too may be a test for whether or not that lesion is a lymphoma or not. And this again alters management, because if it is a lymphoma, you're looking at that patient in greater detail and offering more treatment. Benign lesions may mimic testicular tumors, and a patient may not always give you a history of trauma to the testes to tell you that this is actually a benign lesion. Color Doppler, you will not see flow in the hematoma, and contrast will confirm this for you. And it gives you more confidence to sit and wait for the resolution of these appearances rather than moving down the management pathway for a malignant lesion. And if we look at the video clip of this, you'll see that again, because it's not so inflamed, the contrast enhancement is not so florid as it was in the inflamed testes, but there's clear demarcation of these areas as being non-vascular. These are hematomas. Your management is different. Epidermoid cysts are true cysts. They are benign entities, but they have these variable appearances on ultrasound. They're not all the onion skin classical appearance of epidermoids, but may have quite a lot of variation, a lot from the normal onion ring appearances to a mixed, heterogeneous, poorly defined calcified area. You will see that there will be no color Doppler flow because it is true caseous material in a cyst, and the contrast-enhanced ultrasound will show no flow within that lesion completely. And if you look at the videos of this, the areas, you'll see there is compression of the surrounding tissue to give this hyper-enhancement around the lesion, but there's absolutely no flow in that. These two combinations will give you the diagnosis of an epidermoid cyst. I haven't introduced elastography just yet, but the epidermoid cyst is one area where elastography gives you conflicting results. So how do you use the contrast-enhanced ultrasound here? Well, in these two patients, the lesion's in a very similar position. One patient has had a biopsy for infertility. One patient has an incidental lesion on examination for other reasons. This lesion is hypervascular. This lesion shows no vascularity at all. So you can use your ultrasound there to tease out these two patients, and you can probably say, well, this is the result of the biopsy. This patient may have a tumor. Commonest lesion to be found incidentally in the tissue is a benign lesion, and this is likely to be Sertoli or a Leydig cell tumor. Now look at this case. This is a patient with infarction and two seminomas on B mode. You'd be hard-pressed to pick out where the area of infarction is and where the tumors are. Color Doppler gives you some idea, but you add contrast, you see the hypervascularity in the two seminomas, and there's the area of infarction within the testes as well. So at the time of the examination, instantly you get able to give a clear description to the referring clinician, what you think is going on, and the management is of course different because these two seminomas will warrant a orchidectomy. And then you get surprises. This is an indeterminate lesion. The patient left testes here, but he actually had pain in the right testes. He's 66 years old, so this may well be an area of lymphomatous change. How can you help? What can you do to help with the adding contrast enhanced ultrasound? You see it's hyperemic here. But importantly, and we didn't realize this at the time, we thought this was a benign lesion, the pattern of enhancement with contrast, but it was too big to do testes sparing surgery. But it turned out to be a capillary hemangioma of the testes, very rare. But look at this, which actually, and we didn't know this at the time, but look at the pattern of contrast enhancement. It's that globular enhancement around the edge, like the hemangioma in the liver, which may give you a clue. This is very rare, but it shows you that hemangiomas behave quite similarly in different areas of the body. The guidelines at the time in 2011 had these recommendations for the use of contrast in scrotal diseases. These may be modified the next time we do them in July, because there is more literature out there now and recommendations will change. But really, it's whether or not the main recommendations are whether or not that lesion is vascular or not vascular. You can find non-viable tissue and testicular trauma and segmental infarction and the abscess from severe epididymolysis. I think those indications will roughly stay the same, but it's a differentiation from benign and to malignant vascular tumors that may change. And this is some of the literature out there from our group at King's College Hospital looking at multiparametric imaging of the testes and just giving you a general overview of the ultrasound of the testes if you're interested in looking at that. But why not see what elastography can do? Well, elastography is just a measure of the hardness of the tissue. It's the palpation of the tissue. If the tissue is palpated, you can just feel it and squash it. But very often these are intratesticular lesions and you can't feel these lesions. I'm going to show you images of strain elastography, not shear wave elastography, because I think strain elastography is quite useful in the testes. For instance, here's that seminoma we saw earlier. Blue is hard here with this elastography from the Hitachi machine, and you can see that it's much, much harder in that focal area. You can do what's a strain ratio of measuring the strain in this area to normal tissue, and you can see that that area of tissue is 43 times harder than normal testes. This has to be a malignant lesion. This is a lesion which is the abscess of the hematoma from earlier on. You can see, yes, it looks low reflective, maybe a little bit suspicious, but the elastography showing some fluid, etc. in there shows it's just really not that much harder than the testes. You're confident this is a benign lesion. How can you use this with the indeterminate lesion, where you find this incidental lesion in a patient, you don't know what to do with it? Can you watch it and leave it? A patient may not be happy to sit and watch and leave it for a while, but add all your multiparametric imaging, add your elastography, your color Doppler, your B mode, your contrast, and make a diagnosis. Well, it's a little bit vascular on the color Doppler. With the elastography, it's not really that much harder than the rest of the tissue. I mean, it's hypervascular. We think this is a Leydig cell tumor based on these things. We think it's benign. Incidental lesions, 80% are benign in the testes. Let's offer this patient testes sparing surgery. So we put it through the software program, look at the enhancement pattern of the contrast, look at the various parameters to make sure we're not just eyeballing it, but we have quantitative thing. And this has been repeated by Dr. Cantisani's group in Rome, looking at differential diagnosis of non-palpable lesions using contrast enhanced ultrasound. And then we go with the surgeons into theatre, find this lesion on ultrasound, out it comes, we put the lesion in a water bath and scan it again to make sure it's come, and we can say, yes, well, there we have it, we've got the lesion out, Histology will tell us whether it's benign or malignant instantly, and if it's malignant, the patient may or may not go on to an orchidectomy, but certainly if it's benign, you've saved the patient losing the testes. And just to round up and summarize using multiparametric imaging, the different types of tumors you see, this is a seminoma, and these images are taken from that paper I showed you earlier on. Focal lesion, quite small, a little bit vascular, very hard on elastography. Contrast not as good as enhancing as that Leydig cell tumor. This is another indeterminate list, and this is that epidermoid cyst that I showed you earlier. No vascularity on contrast, and this is the one time that elastography shows you to be very hard, and that's because of the caseating compacted material that forms that onion skin within that cyst, and it looks like it's very, very hard. But the clue is that it's completely avascular, and you combine it with those classical appearances that you see on B mode, an epidermoid cyst. This is an embryonal cell tumor, and one of the things we've found with embryonal cell tumors with contrast-enhanced ultrasound is that they're less vascular than any other germ cell tumor, but because of the technique, you'll be able to see a single microbubbles traversing that tumor, and you know it's not avascular, and combined with the hardness, you know you need an orchidectomy. Segmental testicular infarction, no color Doppler flow, no vascularity, some hyper-enhancing rim to it, and the elastography just shows you a really quite soft area compared to the remainder of the testes. Again, you're more confident. So how can we use this in indeterminate lesions? Well, maybe in the future, when you're looking at these lesions in the testes, the incidental lesions, if it's a Leydig cell or benign tumor, it is heterogeneous, maybe highly vascular on color Doppler ultrasound, rapid and longer enhancement and contrast enhanced ultrasound, and softer on elastography. A seminoma will be more homogeneous, less vascular, rapidly washes out, and is hard. This, I must stress that the literature is not complete yet, but this is the way pattern of differentiation and diagnosis that you may be going through in the future. Like everybody else invited you, I'd like to invite you next month for this course in London. Please come to it. It'll be very comprehensive, 2-day course, fully catered with a course dinner overlooking the river. You'll enjoy it. Thank you very much.
Thank you, Paul. Excellent presentation. Superb panoply of all the testicular disease that you can detect and characterize by using multiparametric ultrasound. We have 2 questions for you. One from Latina, Piero Maceroni, who is asking you, do you have any experience with the new software for microvascularization such as SMI from Toshiba, superb microvascular imaging?
I personally don't have experience with it, but I've spoken to my colleagues in the United Kingdom who have, and it's very promising. The SMI seems to be able to pick up vascularity in very small lesions, and it may help. But we're in the early days now, but it is promising.
Yeah, I have a similar experience, and I use it in several fields, also including testes. And especially if we add SMI after contrast agent, we may achieve even more, even better results in defining even small, tiny vessel. Second question for you from Alexei Borkulov. He asked which kind of ultrasound elastography techniques you are using in your daily practice, strain or shear wave for testes?
For the testes, I'm still strain elastography rather than shear wave. Shear wave is not as consistent yet in the small imaging of very small superficial structures, but it is improving. My experience remains with strain and a subjective assessment of it, but shear wave will come in the future. But we have the problem, as Odd Helga said previously, that different machines have different values for shear wave, and even machines with strain elastography, the patterns look so different. So until there's uniformity, you have to be familiar with your own practice at the moment.
Thank you. I agree. That's the reason, because we are starting with the updating also of elastography of liver, and soon after we have to put together our experience to try to provide a sort of vademecum, an interval of values to try to have a clarification between all the techniques. So it appears that no other questions are available from the audience. Time is over. I believe and I hope that all the participants have enjoyed this second webinar. I thank so much Professor Odd Elgegia and Paul Sidhu. We tried to give to all of you our experience and the update of literature in CUS beyond the liver. I announce also that we are going to continue with this experience with other webinars. But sorry, I received right now a last question. So we have time just for the last question from another expert from Italy, Antonio Pirmasciota from Molise. Is asking, what about CUS in testes for infertility? So please, Paul, do you have any experience in that?
Very little experience in infertility with contrast-enhanced ultrasound, but the observation with elastography is different, and I think elastography may be a better thing, because if you're doing strain elastography on the testes, near the tunica albuginea, it's more fibrotic, and there's with the Hitachi machine with blue showing hard, there's a rim of blue around the testes. If you have got an atrophic fibrotic testes, that the testes becomes harder. Shear wave elastography, I think that may be a better indicator of a diseased testes. Contrast, I'm not so sure that it'll be at the moment of value, because the technology of looking at an uninflamed testes with contrast is not there, as is uninflamed bowel as well. You have less enhancement, so not yet.
Thank you, Paul.